I have with me Catherine Sozi, and she's the Director of Regional Support Team for Eastern and Southern Africa of UNAIDS. So you're welcome.
Thank you very much, Legacy.
Yes, there's been a lot of talk about meeting the target, the 90-90-90 target. Now, in simpler terms, what is the 90-90 target all about?
Right. Well, firstly, as UNAIDS, we do our best as global advocates for really making sure that we work towards the end of AIDS by 2030. This is a promise that we made with member states in 2015, and so we have agreed, and we've been asked by the member states to support them to make sure that they work towards this. One of the actions that will lead us to end AIDS as a public health threat by 2030 is making sure that as many people as possible who are living with HIV know their HIV status, so that they can be put on antiretroviral treatment and that they can live productive lives. So one of the first things for us to do is to get political buy-in by governments and commitments by governments. And setting the target of 90-90-90 is a way of getting that buy-in and being ambitious to make sure that governments make sure that everybody who deserves to be on treatment is on treatment, and they start on treatment as soon as possible, and then they're supported to remain on treatment so that the treatment actually does what it's supposed to do. Because evidence suggests is that if the amount of virus in the blood is very low, actually people living with HIV on treatment can live as long as everybody who doesn't have HIV. Yes. So the 90-90-90 looks at three things. Firstly, the first 90 is about trying to get as many people living with HIV to know their status. Because what evidence suggested before the UN General Assembly when we made that promise was that actually there were a lot of people who don't know they're living with HIV.
Really?
And so when they don't know they're living with HIV, they die of HIV-related illnesses. And it's a unexpected death for when there's actually something that you can do about it. So really pushing HIV testing and making sure that ministries of health and governments and communities make communities aware that they can go for quick, rapid testing. It doesn't need a big syringe of blood, it's a fingerprint prick, or just taking a swab in the saliva and encouraging people to test. So that's the first 90. Every country we said, please make sure that you put systems in place that 90%, at least 90% of the people we think who are HIV positive are actually found and know their diagnosis. Then for everybody who is found to be HIV positive, they must start treatment as soon as possible.
Okay.
So you've probably heard about the test and treat.
Yeah.
Test and then start on treatment. And with all the advocacy that UNAIDS has done over the last decade and 20 years, we've managed to reduce the pricing of antiretrovirals. So most of the governments on this African continent were able to provide regimens that mean that people can take the treatment. In the old days it used to be 18 pills a day, 12 pills a day, and now we're talking about 1 pill a day. So we're saying that nearly everybody who is tested must start on treatment as soon as possible. There must be no delay. It's adults, it's children, it's adolescents. And then we're saying that it's not just about starting people on treatment. We're saying that everybody who starts on treatment must be supported to continue taking that treatment, so that nearly all of them are what we call virally suppressed, meaning that the viral load is undetectable, what we call undetectable, and so the virus is less likely to damage the organs of the body, the brain, the lung, and actually they function just as well as if they're HIV negative. It doesn't mean that the virus is gone.
But it just means it's undetectable.
But it means that somebody can have a good quality of life. They don't fall sick, they don't get TB, they don't get other opportunistic infections, but they need to be supported to take that medication every single day for the rest of their lives. So that's what the 90-90-90. It's an ambitious target to encourage.
And it all has to be done by 2020.
Well, that is the goal, and we made that promise in 2015, and we're now in 2018. That is one of the things.
So when 2020 comes,
we've only got 2 more years to go, and so the purpose of this conference is to see where our country.
Now, looking at the region where you work in Eastern and Southern Africa, how far are you from working with the government? Actually, the governments of the various countries where you work, how far are you from reaching that target in relation to the work you do?
It's definitely clear there's been political commitment from governments in Eastern and Southern Africa. This remains the epicenter of the epidemic still, and all the governments, I would say, in Eastern and Southern Africa are committed to ensuring their 1990 targets. And so our work has been ensuring and making sure that their partnerships, the donors are working with the governments, the civil society and communities are being informed of the need to go for testing and turning up for support. And so really within the last 3 years there's been a really good exponential increase in the number of people who've started treatment and who are also maintaining viral load suppression. But some are slower than the other, and it's not as if there are no major challenges, and the major challenges are really two. Most of the people who are testing remain women. Women are testing much more, starting on treatment, are not being brought forward by guardians and parents for testing.
Why?
I think it's a combination again of parents and guardians thinking that, well, maybe it's too early for the child and it's emotional, and communicating with healthcare workers who may not be communicating adequately to convince guardians that yes, this child can survive. And so in the old days, even HIV positive children were used as proxies for getting to know an adult status. But more and more the push now is to say healthcare workers go in households, go in homes, look for children who are not thriving, and one of the things that needs to be done is an HIV test. And then the third group is adolescents, young people. Adolescents, particularly the young adolescents, 10 to 15, 15 to 19.
10 to 15, 15 to 19.
Yes. And some of the issues around that is really getting permission. If you get a young teenager going to a clinic and they demand or they ask for an HIV test, they will be asked, well, why are you coming alone? You consent.
Is it the health workers or is it the gatekeepers asking that question?
Yes, it is. It is. And sometimes the laws in the country do not allow for a child to just turn up and ask for an HIV test. They have to be accompanied by a carer. And that itself is a barrier. But also the other issues of stigma and discrimination that don't allow for children to turn up in a normal health facility which is not friendly.
So this is kind of like workers, sometimes like a cultural barrier to it.
It's a cultural social barrier which says, okay, why are you here by yourself? Who are you coming with? And why are you coming here? Well, if you're thinking you've got an HIV test, have you been having sex? Are you are you sexually active? So a lot of barriers that are not kind and encouraging for adolescents to turn up to facilities.
Okay, let's look at specific programs that you've been doing in the region where you work. Let's look at what you've done, anything ongoing, and what you hope to achieve.
Yeah, well, at the moment the focus is on adolescents because they're the population where the new HIV infections is not reducing at the rate in comparison to everybody else. In this region, in Eastern and Southern Africa, we have on average about 4,000 new HIV infections every week.
Is there any particular country within Southern Africa where this is happening more?
A third of new infections are taking place in South Africa, and 50% are taking place in 7 other countries in Eastern and Southern Africa. So the bulk is within South Africa. And then Zambia, Zimbabwe, Malawi, Botswana, Namibia, Lesotho, and Swaziland. So we've got a focus on those countries.
Any country that has done extremely well, or
there are countries, all of them have done very well. By the way, I don't want to paint a picture of doom.
No black sheep.
I don't want to paint, because even South Africa, which has got the biggest burden of new infections in the world, has made extreme progress over the last few years. They've got nearly 4 million people on antiretrovirals. No other country in the world.
Or is it within within which key population? Is it within the adolescent?
With adolescents, adolescent girls and young women, between the ages of 15 to 24. So that is our major concern. Is that even as the country is doing very well in putting people on treatment, you still have to turn off the tap. Otherwise, you will just keep opening the tap and having to put more and more people on treatment, and that is not sustainable.
So what you've done so far, ongoing, and what you propose will still be within the young people?
That is it. Not only adolescent girls and young women, but also what we call key populations.
Key populations.
Female sex workers, men who have sex with men, people who use drugs, and then each country has its own definition of key populations: truck drivers, prisoners, that kind of thing.
Okay, let's look at the relationship within where you work and other African countries. Is there any collaboration, any coordination within what you do?
Well, with every country office that we have in Eastern and Southern Africa, we've got a country office. Every country, we've got a country office. And we work very well with our regional office in Western and Central Africa. And in fact, we'll be working towards presenting what we call South-to-South collaboration, so Western Central Africa can learn from the Eastern and Southern Africa region on some of the best practices.
So kind of exchanging ideas
within our context. So for instance, even within this region itself, we've got a delegation from Kenya going to South Africa to look at how they've managed to scale up such a treatment program under really very difficult circumstances. We're also exchanging how different countries work on key populations. For instance, some countries like Rwanda has got a good program on LGBTI communities, whereas others are struggling a little bit with the laws and provision of services. So there are ways of working together that we facilitate as the UN.
Okay, looking at your report here, the current report here actually, there's a lot of focus on young people.
It's on adolescents.
Yeah, young people. And you did talk about the men, but there's not much about the men in here.
There is a little section actually on partnerships on some of the photos, but we need to talk about the men and the boys particularly, because the relationships are not done in solo. The relationships that are taking place are happening with boys and young men. And in fact, the issue is that the young women are having relationships with men and boys who are about 8 years older than them, and who are infected. And when they move into the next age group, they then look for men who are their peers to settle down and have relationships. Those same men then infect young women. So there's a bit of a vicious circle. Relationships there. Well, of course, you can have same-sex relationships, but the majority of relationships are men and women in all their diversity. So addressing the response for men is key, and that's why we have to push for men to have information, to understand the risks, but also to enter the programs and know their status and be started on treatment as quickly as possible, because the men are the ones who are tending to die, and they die not knowing the HIV status, they die not being on antiretroviral treatment.
Yeah, looking at men now and boys, we're now beginning to see a lot of transgender issues, and they're part of the key population. Men sleeping with men, young boys who are having, male partners. And in Africa, we know you don't talk about such things. Don't you think this would be a barrier to trying to achieve the 90-90-90 target for 2020? How do you hope to achieve all this and, send out a campaign that will make Africans begin to accept this key population within issues relating to HIV and AIDS?
Certainly, if we don't accept, then that barrier means that we will not achieve 90-90-90. Because one of the things that's happening is that there are people going to be left behind. We must remember that the people who we term key populations are citizens of our countries. They are daughters, sons of our families and communities. And the more you discriminate, the more underground the populations go, and the more likely HIV basically will just continue if people do not have access to services and they don't have access to treatment in the same way. Our push as the UN is that everybody is equal, regardless of age, sex, race, who they choose to who they sleep with, and so everybody needs to be treated equally to have access to the same services as everybody else. So part of our advocacy, and it's happening, it's change. I mean, even in the Southern Africa Development Community, SADC community, for the first time we have what we call a key population strategy, which has been endorsed by all 15 member states. And it was developed together with the key populations. They sat in the same room with the government policymakers and programmers and informed them on what their needs are and how they can be reached. And that strategy was endorsed by the ministers of health.
But they've not started. Have you started?
Oh no! Yes.
Some have started.
Yes, some have started working with them, and you can go to some of the public facilities, and you will find health services being delivered to men who have sex with men and gay men. You do have recognition of transgender